So in the interest of time, we'll just quickly summarize the positive findings. The 1.5-year-old child with shoulder sequelae of you don't call it OBPP anymore, birth brachial plexus paralysis, BPBI, in origin, with functional limitations of abduction and external rotation, with tight adductors and internal rotators at the shoulder, with deficient abductors and external rotators at the shoulder, with a persistent internal rotation contracture of the upper limb and an entire version, with a slight flexion deformity of the elbow, with a normal forearm, wrist, and hand. So, persistent flexion deformity, but power in a 1.5-year-old child will be difficult to judge. So instead, you will judge it by Mallet grades of composite movement, which is grade 2 in this child. Grade 2 abduction is actually a composite score of 25 points. But when he's in a better mood, then you have to score each movement. Hand to overhead abduction, hand to head, hand to mouth, and hand to side, and hand to back. So all these 5 points have to be scored from easy, difficult, and completely impossible. So he comes in the difficult category. So almost at everything, he'll probably get a 2.5 kind of a score. So I don't expect him to get a Mallet grade beyond 11. And what I would propose to do is, now that he's 1.5 and he has an established contracture, we will definitely propose operative treatment for this child in the form of an anterior shoulder muscle release and a posterior conjoint tendon transfer. Posterior muscles are the latissimus dorsi and the teres major. So if you have an isolated deficiency of abduction, you will use a single muscle, because by taking away the adduction, when you're taking the teres major away, when you're taking the pectoralis, you're weakening them. Just by taking away abduction comes as a beneficial side effect of the surgery. But when you have abduction and external rotation both restricted, then you need a double muscle, both the lat dorsi and the teres major as a conjoint tendon, to be transferred either to the greater tuberosity or to the infraspinatus, which is extraplexal and which has recovered. So you will do that to the rotator cuff, so that you can get a full abduction as well as an external rotation. This is the lapiscopo transferred, modified now. Along with that, when you add the anterior release, it is a little bit of a take on the Chuang's transfer. So both these papers you should be reading up, and we'll try and put the links up on the YouTube channel. Yeah, so we'll go ahead with the next case. So investigations, you would want to investigate this in the form of, one is, if you have a well-trained ultrasonographer, you can either do that to see, just as you have the graphs angles, you can have those angles described by a sonologist, but most of the people are not familiar with how to do a sonography for a shoulder in a child. So better to do an MRI in such a small child, because up to 5 years of age, it's largely cartilaginous. So what you'll want to look for is angle of retroversion and percentage of humeral head subluxation. Retroversion in a child improves from about 9 degrees to 11 degrees as they go on maturing. Most of the time in OBPP, you will find it usually 15 or 18 degrees. So it is a little excessive. The hip in a DDH is anteverted, whereas the humerus is usually retroverted. So extra retroversion means the glenohumeral articulation is disturbed. And percentage of humeral subluxation is when you draw a long axis when you draw a line passing through the long axis of the scapula, it should bisect the head 50-50 on either side, so that the globe remains 50% anterior to the transverse scapular line. In OBPP, you'll find most of the head of the globe is posterior. So again, we'll try and put up these slides and pictures along with the YouTube link with this child, since he was not too cooperative. We'll try and put up slides of the same. And EMG, the last line I will say is EMG has no meaning in a shoulder sequelae. OBPP has usually finished its recovery by the end of 9 months in an upper plexus and 1.5 years in a global plexus. So therefore, there's no role of EMG anymore. The only time you do EMG is at 4 to 6 weeks when you want to establish the initial lesion. And then for the first 9 months, if you want to see whether recovery is progressing or no, Or if you want to see a case where there is absolutely no recovery and you need to make up your mind whether to put this up for a nerve grafting and repair.
Ma'am, I'll like to ask, in this case, the trumpet sign is positive. He's able to abduct, but not able to flex. So the aim of surgery will be to achieve elbow flexion, or like just abduction to be
No, you are not treating the elbow flexion at all. The aim of surgery is to restore his shoulder movements. Okay. His true humeral movement of 90 degrees, pure abduction is already there. Okay. So what you want is overhead abduction, which is a scapulothoracic movement. Okay. So the minute you take away the adductor, what is going up to 90 will easily go up to 110 or 120. Okay. And you will treat the elbow flexion deformity with the use of either splints or serial plasters.
So his flexion of the elbow is not necessary to be treated.
So we can,
or he can use the
beneficial. You need some amount of that. You need some amount of elbow flexion so that he can bring the hand to mouth. But if there is a persistent flexion,